Okay, this is a new case. This patient has a history of blunt trauma to this eye with a temporal iridodialysis. You can see in the bottom right-hand corner of the picture. You can see that his pupil is decentered as a result of the small iridodialysis. He also has a sectoral cataract in the same location. So you'll see a dense white cataract in the same place that iridodialysis is in just a minute. So what we're going to do is take out this cataract and hopefully not have severe zonular problems. We're going to put a Malyugin ring in to start with to help with pupillary dilation. You can see that goes in pretty normally. We want to be gentle, obviously, with the iris since it's already has a defect, but I didn't have much trouble getting this Malyugin ring in, and once you see it in there, you can see that dense white cataract on that same side where the iridodialysis is. So next we'll proceed with the Capsulorhexis. This is where we're going to see how bad the zonules are, because often you can see the rhexis tear abnormally. It'll often fold up on itself or wrinkle whenever you pierce it with the cystotome, or even when you start the Capsulorhexis with the Utrata forceps. So I probably made a small mistake here by letting go of the anterior capsulotomy right in the area where the dense white cataract is. You could have made an argument for staining with trypan blue in this case to improve the view. I've actually kind of stopped the surgery and I'm trying to wake the patient up. He actually had propofol for his retrobulbar block, and he was really snoring loudly and his head was bobbing up and down. And so when I was struggling to grab his rhexis to bring the rhexis all the way around, I made the decision to sort of stop things, wake him up, and try to get him to hold still for me for just a couple of minutes so I could finish his rhexis. You can see here I keep trying to grab the rhexis, but I really can't see the edge of it because I've stopped in a bad location. So my advice is, if you have a place where you don't have a very good red reflex, try not to let go of the rhexis in that spot. Obviously this was a tough case where the patient started moving right when that happened, and so I was able to get him to wake up from the propofol. He slept for several minutes before we were able to arouse him. But once I get it back to where I have a good red reflex, you can see that the rhexis tears very normally. We don't see that wrinkling or folding of the Capsulorhexis that suggests that we have a severe zonular dialysis. So one of the most important parts of any cataract surgery is getting a good hydrodissection and getting a nucleus that will rotate around inside the bag. But that's especially true if you suspect you might have zonular problems, because nuclear disassembly, and in particular trying to rotate the nucleus, can really stress out the existing damaged zonules. So I spent extra time here hydrodissecting with the chain cannula several times, quite a bit more than I normally do, to try to free up the nucleus from the bag. You can also get a sense for what kind of zonular problems you're in for at this stage, because if you try to move the nucleus around like I'm doing there and you see the entire bag complex move, you know that you could end up with a lens on the retina. The cataract can actually fall all the way onto the retina. Fortunately, I didn't see anything like that, and we're going to proceed with phacoemulsification. This lens, fortunately, is not extremely dense. I did, however, change my normal settings to the dense lens mode. Again, the same concept here is, if I have more phaco power at my tip, I don't have to push as hard on the nucleus, and thereby I may save a few zonules by increasing my power, even though the cataract isn't that dense. I don't care as much about the CDE in this case or how the cornea does. I'm really trying to save his zonules as much as possible. I have this sped up a little bit just because it kind of is a normal nuclear disassembly. You can see that the lens is rotating very freely in the bag, Now I use a divide and conquer technique, get it into 4 pieces. And again, on a case like this, we want to suck in the smaller pieces first. So I have an asymmetric crack that wasn't intentional, but I certainly was aware that these 2 pieces I just took were smaller than the other 2 pieces. So let's take them first, clear up some space, and then we can take the bigger pieces next. I actually groove again here, which I don't normally do. Normally I just do 4 pieces, but in this case I felt like grooving again, doing more phacoemulsification in the bag, and less manipulation of the really large pieces of the cataract would be better for the patient. You can see when I free up the nucleus here how dense that white sectoral cataract is. It phacoed pretty nicely. The CDE in this case was not extremely high. So I finished nuclear disassembly. I'm looking at my Capsulorhexis here. Another sign of severe zonular problems is when you tore a round rhexis and now it looks oblong or misshapen. That's really a sign that you have severe zonular problems that have worsened throughout the case. And you can see I have a pretty well-centered capsulotomy with it being pretty round still. And so I'm just going to mash in these remaining nuclear pieces into my INA port. And again, we're going to carefully watch the bag. We're looking for the equator of the bag to come towards the center. If we see that, we know that we have some really bad zonules. So you can see I've made progress on the Cortex removal here. I've intentionally left the last clock hour of Cortex being right underneath where I think I might have the weakest zonules, where the iridodialysis is. And I'm carefully removing that. I get a sense that I'm not getting a normal resistance here. I'm also being very gentle. I'd rather not pull really hard on Cortex in this spot. I think it's possible to be aggressive with Cortex removal in this situation and actually come back with vitreous because I highly suspect that the zonules are not normal in that area since this patient had a sectoral cataract with an iridodialysis. So I've got maybe a clock hour worth of Cortex still in there. That's fine. I can always come back with YAG laser later on. I'm going to fill the bag here and we're going to put in this CTR. It's a preloaded CTR. It's called RingJect, and a shout out to Jesse, my favorite J&J rep, for getting this. I like the preloaded version. The hospital I operate at was unable to get a preloaded version. I tried initially to just use a one-handed technique to inject the CTR, but I felt like it was catching a little bit and I didn't want to push really hard. So I've used my Sinskey hook here to increase the contact point on the bag and allow me to inject the CTR fully into the bag. I really like the way it lets go at the end. A lot of injectors, you actually have to use a second instrument to get it to release, and you can see in this one all I had to do was push the plunger all the way forward to get the CTR to release. So we have a CTR in the bag now. At this point, since there's a CTR in the bag, it doesn't matter what kind of lens you use, in my opinion. So I'm using my standard one-piece lens. I did switch from an iHance, which is what I would use in most patients for my monofocal lens. to this is a DC boo. The rationale here is if I do have a little bit of decentration of this lens, I'd rather it not be an Eyehance or another type of eat-off lens that could be more sensitive to mild decentration. So small change to the normal lens that I would use in a case, but you could make an argument for also using a three-piece lens. I think putting a three-piece lens in this eye would have been fine even without a CTR. I actually don't place a lot of CTRs because I think for a diffuse zonular problem like pseudoexfoliation, they're not really that helpful. But in cases like this where you have focal trauma, I think it makes sense. I love to turn my Sinskey hook upside down to remove the Malyugin ring. I find that's a really slick way to get a Malyugin ring out of the eye for those of you that are struggling to remove your Malyugin ring from the eye after you free it up from the iris. So we checked the wounds carefully for vitreous. There is none. I did have a little bit of posterior pressure at the end of this case, but you can see hydration of the wounds was sufficient for a watertight seal. The lens is well centered. Just a little bit of Cortex there, but like I say, we can always YAG that later on. I think that's much safer for this patient. And I appreciate your attention to my cases. And please give us a like and subscribe if you want to see more content. That's all, folks.